We have love for Africa. There is hope, hope in Africa. We are serving Africa. We are serving Africa. With all passion, we are serving Africa.
Health is a major issue across the globe. Africa, no exception. Epidemics, from Ebola to all other epidemics that we can think of. Lack of medical facilities and adequate numbers of professionals trained. Let's watch the next video to see what's happening in Africa.
Across Africa, simple access to healthcare is a massive challenge. Less than 50% of Africans have access to any health facilities. The situation is made worse due to a lack of trained doctors and health professionals, with only one doctor for every 5,000 people. But this is not surprising, as only 170 medical schools exist in 47 countries in Africa, with some countries having none whatsoever. This also becomes problematic when it comes to natural disasters, where tens of thousands can be killed and millions affected every year through droughts, floods, and epidemics. And with Africa being the poorest continent in the world, various governments can struggle to provide the assistance and provisions needed in such times. So without vital help in their time of need, whether for health issues or times of disaster, millions of Africans can find themselves suffering needlessly.
We do have Dr. Shanawaz Rashid with us, who is the Director for Global Health, Humanity First. Welcome, Dr. Saab. Could you tell us more about global health?
Well, there is a crisis happening across the world in terms of the distribution of resources. And one of those big areas is that of health. If you look at the richest countries in the world and you compare them with those where there are low or middle income in those countries, the disparity is huge in terms of both access and delivery of healthcare. Now, what does that mean? That means that in some places in Africa, 1 in 10 women do not survive childbirth. If you compare that to somewhere like a Western country, that's 0.001 women might die in childbirth. It's a really rare occurrence. But why is it that in some places women don't make it through the very act of delivering a child? Also, children themselves. The rate of babies who die during childbirth is also extremely high. Now, why is that? That's partly because the facilities are not there. It's partly because training is not as good as it should be. And sometimes there's women who may be delivering a baby in a health center in a district, a rural area. Now, if she doesn't manage to deliver normally, then she might need a cesarean section, for example. And she might have to be transferred to a tertiary hospital, a more developed hospital, which might be 100 miles away from where she is. And many women then will be asked to take a bus or other transport to make it to those hospitals. And the roads are awful. And often they might die in transit, they might die when they get there, either of bleeding or because of infections. And that's not a situation that we have to continue with.
Well, it looks a bit gloom and doom. Dr. Shabir Batisab, you are in charge of Gift of Sight program and also the Vice International Chairman for Humanity First. What do you have to say about the crisis on eyesight or gift of sight?
Well, this is one of blindness is a very important condition which is prevalent in Africa. Well, I should say in the third world, basically. And it's so easily remediable, but the facilities do not exist. And it's not very, it's not very costly to do an eye operation to remove the commonest cause of blindness, which is cataract. But the facilities are so poor that many people across the continent in remote villages will not be able to see their kids grow up or their grandchildren born. simply because of the effects of the blindness that's affecting and blighting their lives. And this is something that can be remedied only if there were enough resources targeted towards this common condition of misery.
So what are some of the facts on the ground? Do we have a very serious calamity on our hands, or it's more moderate, something we shouldn't be concerned about?
No, it is fairly serious. I mean, it's not that calamitous that it actually affects it causes the country to go into a decline or something, but it does affect economic development in a country which needs all the resources it can get. Also, the factor of human misery and well-being is important here. We in the third world have got extended families and we look after ourselves. Now, if you are leaving your kids in the charge of an elderly family member, and that family member cannot look after the kids, you are naturally hamstrung, and your economic output for the family is blighted as a consequence.
Economic consequences, lack of facilities and well-trained professionals. Mr. Tahir Ahmed Saab, you are the Deputy Director for Global Disaster Programs or Disaster Relief for Humanity First. What are the facts on the ground? How does it look? Is it also doom and gloom for Africa?
No, not at all. Not at all. There was a time and there was a place within the country where it was heavily reliant on external assistance. But there's been a massive shift in the humanitarian community where they are focusing on doing something called building capacity. And what that means is training local people, just like you and I, to conduct humanitarian operations. That may be disaster relief or disaster response, or maybe more advanced things like first aid and medical training. And that's helping massively. That's part of an overall plan called disaster risk reduction, and steadily improving the infrastructure of disaster response in Africa.
About 50% of Africans don't have access to proper, adequate medical facilities. What do you have to say about that?
I mean, I think it's wrong. I do. I think that there are some basic human rights that all of us as human beings should have. I think they include health, education, shelter, water and food. And I think as a world, those who have these things should see it as a individual personal responsibility to make sure that everyone has those things.
So are you saying it's not the fault of the government, or the individuals should take?
I think humanity has to take responsibility for all of humanity. So I think that if we have those things, if we have the benefit and the opportunities and the resources, then it's more than just a target. I think it's an absolute duty that we have to contribute and help those who need help. We have to look at the children, whether in Ghana or Gambia or across all of Africa, like as though they are our own children. And I think unless that changes on a global level, then we're going to struggle. But what we shouldn't do is we shouldn't patronize. I've been to many countries in Africa and had the privilege to work alongside many African doctors. There's a huge amount of expertise locally, there is. And what we have to do is work side by side, hand in hand. And yes, we might need to support them in terms of some resources, maybe some transfer of knowledge, so maybe some training, but we should do it together.
What would you say, Mirza Tahir Ahmed, is the major issue when it comes to disaster relief?
At a more focused level with disaster relief and on the ground, it's largely due to access, the problems that we have. We have very sparsely populated areas with different communities and different cultures and different leadership that we need to talk to in order to engage with the community. And these are some of the problems we've faced. But also, and it's a well-known problem, there are individuals, there are groups who simply refuse the assistance because it doesn't benefit them. So it's about a programmatic way of working, communication, dialogue, finding ways to work with local leadership in order to benefit the population. Disaster relief in Africa in general is not about going in and putting a band-aid. It's about a long-term plan of how you're going to create outcomes that will benefit the community long-term.
Well. We have been looking at all the challenges facing Africa with regards to global health, gift of sight, and disaster relief. It looks a bit gloomy. Yet, Humanity First as an organization is doing their bit to help solve this issue. Let's go on the grounds and see how they do it and the impact their service is having on the communities in Africa.
My name is Asif Hamid. I'm a dentist in my regular day job, and I've been working in Humanity First for the past 11, 12 years or so. We realized that there was a significant need for oral health awareness as well, both at a primary level and at a secondary level. We treat each individual contact that we have. For example, each student is actually a family that we're speaking to. And that family can then take it on from there onwards. So if we're giving them dietary advice, they know what good diet is, what bad diet is, what's good for the teeth, what's not good for the teeth. So again, these 2,000 children that we will be contacting directly will then have a direct impact on their own families. And as the circle grows, it will be a much larger population that we're impacting.
With me is Dr. Shanawaz Rashid, who is the Director of Global Health Humanity First. Dr. Shanawaz, what are these for?
Well, what you realize is that we need sustainable development for medical purposes, and that means training local people to deliver the highest level of medical care. If you look at many places in low and middle income countries, trauma is a really common cause of death. Young people, they are more mechanized vehicles, there's people being hit by cars. And if someone were to be hit by a car in a rural area, what they would traditionally happen, they'd be put in the back of a truck, they'd be brought to a hospital, and there would not be the facilities to deal with them. So what we're training on is how do you stabilize a patient maybe in the middle of a road somewhere, then how do you bring them into a hospital environment, and then how do you try and save their life? So it's life-saving treatment.
So now, more of capacity building.
Exactly, capacity building. I mean, if I went there, I might be able to treat 1, 2, 10 people in a week, or I could train 10 doctors or 10 doctors and nurses to treat thousands of people during their whole lifetime.
So we're talking about leverage.
It's clear that it's obvious that you're going to have to be raising the standards of the local clinicians in order to really make an impact. So, for example, the person comes into the hospital, the 3 things that kill people are the management of the airway, i.e. how does air get into somebody's lungs, breathing, i.e. how do the actual lungs actually function, and C, circulation, meaning how does the blood transmit all around the body. So what we can do is by stabilizing an airway, i.e. how do we make the oxygen get into someone's mouth and into someone's lungs, how do we support the breathing, how do we support the circulation, that will result in saving life in most situations.
So Dr. Shanawaz, what you're talking about is training doctors on the ground,
doctors, nurses, paramedics,
and the locals on how to deal with blockages in the airwaves, the lungs, and circulation, so that they can deliver first aid and also cut down mortality rates.
Exactly. So that's just trauma. The reason why those babies died that I discussed earlier is because not enough oxygen is getting into them. So simple maneuvers, once the baby's delivered, you can save many children's lives by just simple maneuvers. So if you warm the baby up, if you provide oxygen, if you can assess any problem immediately, you might be able to suction out some of the mucus in a baby's mouth, you'll save their life. And we're talking about the value of life is so high that simple measures will make a big difference.
Simple measures will make a big difference, indeed. What are these for? I can see a paramedic bag. What normally goes into a paramedic bag, and how can this kit save life?
So if you look at somewhere like a high-income country, they have a paramedical service, and that means someone might be able to be hit by a car, or they might have a heart attack, or they might have any other acute medical problem. Then we dial a number. In the UK, it's 999. And an ambulance will arrive with trained personnel. They'll stabilize the person in the middle of their house, or in the middle of a field, or in the middle of a road. They'll bring them to hospital. That immediate period, we call that the golden hour. The golden hour means during that time period, most lives will either be saved or will die. So we can take the equipment that we need, we can, like I said, support the airway, make people breathe, keep them alive for as long as they can be to get them to hospital where they can get further interventional care.
Does Humanity First only focus on training,
No,
human capacity, or you also kit
No,
those you train?
So we deliver the healthcare itself. We've got various hospitals where we actually deliver the care. We also train the personnel, and we also help provide some of the resources available. So this is a defibrillator machine. I mean, you might have seen it.
That's a very long word. What does that mean?
So that
doctor?
means that if the heart actually stops beating, the heart requires an electrical current sometimes to stimulate it to start working again. This is now present in supermarkets in high-income countries. General public people can use this thing, and so they haven't got that even in the high-level facilities in some of the hospitals. So we're providing some of these machines, we're giving them some of the training that they need to do to use them, and we're resulting in saving lives of people.
The overall impact from a surgical perspective is not just us treating them, but we're also creating that awareness. We're teaching the local doctors in identifying diseases, and I'm hoping that in the next 5 years they would not need us anymore, because we would have given them or imparted enough training which would enable them to diagnose their own conditions. I can distinctly remember the first patient I operated in the Gambia, and this was last year in November. I happened to be focusing on purely the teaching aspect, and I went past, and this particular individual was sitting there waiting for me for the past 3 days, because she knew that there was a clinician coming in from England who could help her out. So she had been given a diagnosis by the local doctors of having an infection of the jaw, and they kept treating it with antibiotics one after the other. She's in extreme pain. She was probably 1/3 of her weight, so she was practically about 40 kilos altogether, or even less. She was very, very dull, not very responsive, and all she could say was that I am suffering from extreme pain from my jaw. We decided that if it's something that we could help her with, we should have a look, considering that she had been waiting for the past 3 days just to see us. We examined her, and I kid you not, the moment she opened her mouth, the stench was so foul that it cleared the room immediately. So she was living with that for the past 6 months at least, and she's been given antibiotic after antibiotic, and this was pretty much her last resort. We very, very quickly realized that her diagnosis it was a completely different diagnosis. It was not something which needed antibiotics, and we decided to operate on her. The next day we operated, we said our prayers. The next day we went to see her in the ward early in the morning, and this lady would not let go of our hands. She clung to us for at least half an hour, and then she started telling us her story. So the first thing she said is that, Alhamdulillah, after 6 months, this is the first time that I'm without pain. I cannot feel any pain despite having just operated on her a day before. And then she said that because of the stench, nobody would come close to her. Her children had left her. Her husband had left her. She was thrown out of the house, and people in her village thought that she was cursed. And interestingly, we visited her before we left, and then we went back again in April. And the scenario was, I was operating on another patient, and I had somebody came into theaters and said, there's somebody out to see you. So we left our work, and I come out to the door, and I said, I'll see who it is. And she was the same lady who we'd operated on in November. She was twice her weight. She's eating healthily, and she said, well, ever since you've seen us, I've been pain-free completely. I've gone back to my family. I'm starting to farm in my lands. I'm able to grow my own produce, and I feel that I've got a second lease of life. And at that point she said, there's so many other people who, if people like yourselves would come in and treat them, they would not lose their lives. And had Humanity First not treated me, I would have died. So that enough makes it all worthwhile. And I would not be surprised if she's still there she still comes to see me when I go there this time round.
Dr. Shabir Bhatti Sahab, you are the International Vice Chairman for Humanity First and also doubles as the in charge for Gift of Sight. What are some of the facilities that Humanity First have provided or is doing to help solve these issues on the grounds?
Talking about Africa on its own, we have got 6 functioning hospitals at the moment, major hospitals, and we're in the process of constructing another one in Cote d'Ivoire, Ivory Coast, which will hopefully have all departments in it. We also have, as Fazal Saab mentioned, a couple of mobile eye units which go from place to place to offer eye surgery. We also get trained surgeons coming in from abroad.
Before we go into the trained surgeons, what standard, what level of hospital? Are they clinics, low level, medium, teaching hospitals are we talking about?
They are like district general hospitals where you get referred patients for various specialities. So they're not specifically just one speciality. They have got their facilities to cater for surgery, for general medicine, for child health and for maternity, things like that, you know, the basics. So they're not one speciality hospitals. They are fairly significant and successful.
Okay, thank you. Mr. Tahir Ahmed, what have you done since you are the Deputy Director for Disaster Relief? What have you done with regards to disaster relief in Africa?
I have been involved in the response to the Sierra Leone mudslides, which involves flooding, and then obviously had a huge impact, thousands of lives lost.
So when you say you have been involved, are you saying Humanity First or personally?
Humanity First, we're involved. So people look at deployments, and when people go out there and serve, they look at that in isolation. When there are a group that goes out, it's often a background team, a command and control team, which consists of 20 or 30 people supporting those on the ground to carry out the work they're conducting. So the team on the ground, led by local people, local members of Humanity First, they served over 250,000 people on the ground, delivering food packs and rations, as well as clothing, much needed clothing and sanitation equipment. So, and this is part of an overall overarching theme and strategy that disaster relief has, working with the local partners so that they can obviously help themselves and help the community around them.
Dr. Shanawaz.
I'm sure, Mr. Saab, you're just referring to your personal involvement, because Humanity First itself has been fairly significantly being involved in the famine in Kenya, for example. Sure. And in the disaster of the Ebola, we were very, very heavily involved there. Okay. And also in the care of the Gambia, where the medical facilities were very poor, we've had teams go there to provide and upgrade the medical facilities very recently.
Okay. This is a clarification. I mean, we talk about disaster relief. I talk about disaster relief specifically on responding to emergencies and so forth. There are a lot of things that you can call disasters, but there's a wide gamut of problems that will probably come under the banner of humanitarian crises. And that's probably what we're talking about here.
Brilliant. Dr. Shanawaz, what would you say has been the impact that Humanity First has had over the period in Africa? And are there any personal accounts? Before the program, you did show me some 2 babies who were saved in Gambia yesterday. Could you tell us more about that?
The numbers of stories we could go on all evening talking about numbers of stories, but I will talk about one young man who I remember like as though this was yesterday. I had the pleasure to work in the Gambia. This is in 1998. And at the time, it was the dry season. And in the dry season, you get a lot of people affected by airway diseases, you know, people who get asthma and difficulty breathing. And people were coming in quite a lot. We had maybe 6 inpatients when I was working there as a doctor, and there were very little in terms of the treatments. So in the UK, you'd have oxygen, you'd have all sorts of things. They had hardly anything there at all. And a young man, 17-year-old boy, He came in, we were treating him, he was getting better, and then all of a sudden the electricity went down. The generator came on, and then the generator broke right in the middle of it. So we couldn't give him what we call nebulized treatment, meaning droplets of medicine which will dilate the airways, will make it more easy for him to breathe. And as he was looking at me in my eye, he said to me, "Doctor, am I going to die?" And I looked at him straight in the eye, and I didn't have the heart to tell him how bad he was. And as I was thinking about how to treat him and what to do, he immediately stopped breathing right in front of me, and he died in my arms that day. Now that was 20 years ago now. He would have been, 37? He would have been married, he would have had children. And I think about him very, very often. And I think that if he had been ill with the same problems in the UK, in America, Canada, across the country where we have those resources, he would still be alive today. We had a team who literally came back 2 days ago from the Gambia, a team of 4 specialists. There was a midwife, there was a surgeon, there was a physician, but there was also a psychiatrist, and we can go on talking about those kind of subjects as well, because psychiatry is very poorly supported across all of the low and middle income countries. But our midwife has been training local clinicians, local nurses, local doctors in the management of babies. So she's a neonatal specialist, particularly looking at babies who are just born. And she's acquired us incubators, oxygen supplying devices, and now the babies who were born in that main hospital in Banjul, they've got a much higher chance of survival. And the picture I showed you were 2 little babies whose lives were saved specifically because of the intervention that we've put into that country.
What would you say set Humanity First apart from the other organizations? What's the differentiating factor? What's the unique selling point, as somebody will put it?
Well, the unique selling point with us would be that our administrative costs are very low. So the vast amount of the, let's say, we have pound sterling in the UK or a dollar in the States. So if you were to donate $1, then about 90% of that dollar would go into the operation, providing of the medical facility. Whereas in a lot of other organizations, this figure falls down to 60%, and as low as 30%.
So are you saying with high-paying professionals like Dr. Shanawaz, you are still able to bring down the cost? Are they working for free? Are you working for free?
I mean, we've got a database of hundreds of doctors, of nurses, paramedics who give up their time. Often they'll spend their own money to pay for their own flights to get out there. Now that's very unusual in the modern world, as you understand. So people would have been paid their normal salary at their normal job. They give up their normal salary. They'll leave their own families. They'll leave their own children, and they'll go off and they'll look after other people who need help. Now that's an unusual thing. That's an unusual situation to have. But because of that, then you've got highly professional, highly capable individuals who are some of the top clinicians I'm talking about in the world here, who give up their time and then go out and do this kind of work. So that's unheard of, and it's something that should be commended and indeed supported.
We're talking about our strength as an organisation. We are heavily linked with the Ahmadiyya Muslim community, and as the majority of members of Humanity First are. And I think our strategic strength is the fact that we have that global reach. Wherever we wish to deploy and execute our work, we have people on there in the ground already who can help us carry that out, who know the terrain, who know the language, who know the culture, who can get us embedded in very quickly. This is something called localization, and this is something quite unique to Humanity First.
Dr. Shanawaz, any final remarks?
I'd just like to say, go back to what I said at the beginning. The only way to solve these problems is people considering everyone in that world to be brothers and sisters like themselves. Because if you feel that these people are like your own members of your own family, then what would you do to help them? You'd go out of your way and you do absolutely anything to serve those people who you consider to be part of that global human community.
Well, viewers, we have been looking extensively at all the challenges facing Africa with regards to global health, disaster relief, and gift of sight. It has been Humanity First Organization, what they are doing on the grounds to help solve these issues for millions of people living in Africa. This is 7 Africa. I remain your host, Ibrahim K. Asante. Join us on our next episode where we look at different aspects on how Humanity First is helping solve issues on the grounds.
We have love for Africa. There is hope, hope in Africa. We are serving Africa. We are serving Africa. With all passion, we are serving Africa.